vacate the place for the next live case. Thank you.
Thank you, Dr. Trehan and Dr. Sandeep Mishra. Now we have a live case coming up from Indo-US Hospital where a CTO procedure will be shown by Kenya Nasu. And then from Apex Hospital, Ahmedabad, you have a CorPath that is newer technology, robotic assisted PCI coming up here. I'd also like to mention that simultaneous sessions will start in other halls. Hall B will have chip session, which will be conducted by Dr. Trehan and Ajay Kirtane. That is TCT at NIC sessions in Hall B. Post-lunch, you have TAVR focus session in Hall B. In the Hall C, emergency live casing saving procedures, angiographic CD data presentations will keep happening. And all of us reassemble back in this hall from 12 to 12:30. The most important aspect of NIC, that is NIC data presentation, which will be done by me. And we have very interesting things and newer things, data coming up in this country to share with you. We have started sharing the subset analysis also from this year, so we'll do it. So if it is, if you are, I think chairpersons for today's live case, Dr. Deepak Gupta, Dr. Satyendra Triwari, Dr. P.K. Deb, Dr. Anil Dal. Are they here? Yeah. Dr. Manitosh Panja, sir, you can join. The other moderators are S.S. Murthy, Sanjay, Naveen, Dr. Amar Singhal, Dr. Nityanand Tripathi, Dr. Navjeet Singh, Dr. Sai Subramaniam, Dr. Uday Kumar. And if you are here, please join on the podium. Feel free, it's our meeting, you can feel free. All of those names are written here, come on the dais. And they're ready for the live, sir. Over to you, Dr. Tiwari and Dr. Deepak. Can we start?
Good morning, everybody. So, welcome my colleagues also, Dr. Deepak Gupta and Dr. Panja. So we are going to have a live case, Indo-US Hospital and Apex Hospital, Ahmedabad.
Offers a variety of diagnostic and interventional cardiology procedures used in the treatment of coronary, artery, and peripheral vascular disease. To improve your healthcare experience and provide you with the latest in science for your medical care, comfort, and convenience, Virinchi Hospitals introduces a privileged club for its members called the RTS Club, which stands for Right to Science Club. It is really fascinating to know that healthcare is actually a big data science. Virinchi Hospitals, Right to Science.
Yeah, good morning.
Good morning.
Good morning, Dr. Sharat Chandra.
Yep. And
I am Dr. Satyen Tiwari.
Ji.
With me is Dr. Deepak Gupta and Dr. Panja.
Okay. Morning, everybody. So let's let me introduce, of course, you all know him, Dr. Kenya Nasu. To my left, he is going to do this case. Dr. Deepak is a colleague consultant cardiologist. You all know me, I am Dr. Sharat Chandra. And let us have the patient data slide.
Yeah. Good morning, everybody.
So this gentleman is 61. He is non-diabetic, non-hypertensive. He had anterior MI in 2004, and somebody has done angioplasty in the same year. And many years he has done well, and in the last 6 months he has been getting recurrence of angina. His echocardiogram has shown absolutely no wall motion abnormalities whatsoever. His ejection fraction is pretty good. His treadmill test was positive, and the angiography has shown two-vessel disease. The right coronary had a long, okay, the electrocardiogram, this is what it is. Are there any more slides, Dr. Vasu? All right. So the Angiography showed a critical long lesion in the right coronary artery in the middle, and the LED is filling retrograde with a critical instant near total stenosis. The circumflex does not have much disease. So to make the case easy for the live demonstration, we have done angioplasty of the right coronary a couple of days back. And today's, this is the one that shows, you see the long stent in the right coronary artery, and you can see the LED filling. Next view, please. Yeah, you can see here the distal LED stent filling to about 80%. And next one. Yeah, from here, I think Dr. Kenyanasu would like to speak.
Oh, yeah, this is simultaneous angio shot. So we can see some small connection, but anyway, next please.
Next.
Next please. This is chip injection from the antegrade, but there's some connection is there, but it's very difficult to confirm. So next please.
Scene plus.
Yes. Yes, this is a cranial view, only the antegrade chip injection, but we cannot see distal flow from the antegrade chip injection. But anyway, we can study the antegrade procedure today. So I put the fine cross as a microcatheter at the proximal LED. And then now I'm studying the guide wiring using by the XTR. Okay.
Darker.
Well, sometimes this kind of the region selection is very easy, but sometimes it's very difficult because its connection microchannels its morphology is very complex.
You want this? No, it's.
Dr. Shah, what's your plan? How you, can you briefly tell us and the audience about your
that's
plan?
What, you know, we have done the right coronary the other day.
Okay.
Now he is attempting antegradely only because the length of stenosis is relatively short. Dr. Kenyanasu thought he will try antegrade technique only. And there's a microcatheter, as you have seen, fine cross in the proximal LED. And this is a Fielder XT or normally what you use for a retrograde. And let's see how it goes.
But there is some resistance here. Okay. We cannot take a photo.
No, you can take.
No.
Middle, yeah.
No.
You want what? Cine?
No.
Robert? Huh? Wait, I can not sister. There's no need. Cine, huh? Yeah, he says it's there.
Okay. Oh, a little bit pull back.
You got a machine name cheyadu. Somebody has come and filled with it. And once those slides are ready, the R0.
No, but actually this is not. So inside the stents.
Yeah, you got it.
Yeah, it's not so.
No, that's,
Which wire you are using, Sharon?
this is XTR
Okay.
Fielder. బెలూన్స్ ఉన్నాయి కదా వాళ్ళే లేపుది అది తీసుకున్నాండి ఇక్కడికి 1.2 లేదా
Maybe its channel is not straight.
చూడండి ఎక్కడ ఉంది.
So that's why the XCR cannot go.
They want to use this. Okay.
じゃあガイアネクスト1ちょうだい。ガイア1、ガイアネクスト、ガイア1。ネクスト1やで。So that we need to change the guide wire now. そうそうそう。Well, anyway, XTR doesn't work well. So that's meaning the channel is not simple structure.
Bharat,
Yeah.
Dr. Panja here.
Yes, sir.
You know the decision CTO trial is there. The John Park from the Seoul, there it is disappointing result. It is particularly medical therapy versus the CTO occlusion with combined with the medical therapy is not too much different. It is inferior. So how much
Just
very important trial, no? If there is good
Why out?
electrical flow, that case is not really not needed. Medical therapy is sufficient.
Yeah, you know, Dr. Panja, this is a question that often comes up in interventional meetings, which is the inappropriate forum for that. You know, here we are talking about how to do this learning exercise. Let's see how it goes.
It is a long segment CTO,
Yeah.
which I personally feel it is too capped, and probably you are through to into the main lumen. Maybe you do a AP cranial,
Who is speaking?
AP cranial.
No, no, who is, may I know your good name? No, let him do the way he is comfortable, you know. If it is difficult, then we will, we may change the plan, but
そんな簡単じゃないんだ。よいしょ。よいしょっと。Okay, hello, cranial view. Come 進まないや。
shall we give a shot from the other side and see? Then देखना ही पैरेंट
ダメだな。
No,
Oh,
we
yeah.
can give that. Give it up. Tension again.
So, next 2ちょうだい。
Sorry?
So next one, Gaia one is also cannot work well. So
So you are planning to have a different wire?
yes,
Yeah.
you got it. Yes, Gaia next, Gaia 2.
Conquest Pro or
No,
something
he
else?
is going for Gaia 2.
So maybe this kind of the stent restenosis usually plaque is very hard. So back to the audiocranium.
Yes, areocranial. This is better.
Bharat,
Yeah,
so preparation of the tip of the wire is very, very important. No, if it is this small cut, at least 10 to 15 millimeter from the distance of the tip of the catheter is also important. How we prepare this tip? Could you please this?
doctor, you
Tip of
want to
the
know how do you, yeah,
Store fluoro?
save it.
Store?
He gave a bend, you know,
Could you inject?
yeah. I'll come and do it, no problem.
Conquest Pro लिया है 9 है.
So can I see the distal already? Yeah, please. Please,
Move
distal,
the
distal.
Table.
Push.
Yeah,
Okay,
Good.
let's go.
So your wire is outside the, yes, it seems you are in the main lumen. Yes, through to the
very good,
lesion
excellent,
to the apex.
Okay.
Yes, that's good.
beautiful.
Good.
So he wants to know, why did you change from Gaia 1 to Gaia 2?
Actually, the guy one cannot advance in the anymore. I have some resistance inside in the mid of the stents. So that's why I think the
Extension.
plug is very hard.
Extension.
So the guy one is
No,
chip loaded
no,
only
no, but the
1.87,
extension.
1.8. So I think I need the more harder wire. So can I see the guiding?
Guide, please.
Okay.
Yeah. Lovely, beautiful. Okay,
Okay,
table,
store. Sure. Okay.
stored? Good.
So you want to change the wire? Which wire you are?
The regular wire, I always use the Xion from the Sahintech.
The Sion wire, a regular
Sion.
wire.
Okay, plain, Sion
Yeah,
plain
yeah, plain
or
Sion.
blue?
Just a moment. Take out. Take out.
Okay. You want to avoid air being going in, yeah.
So now
Give
we
a
can.
indiflator.
Can I see the distal already? Distal.
Okay,
The
so you
2.5
are
one, please. 2.5.
the Sion wire so that you can see the length of the segment.
Deepak, come here.
No,
No, we got time.
we don't need. So you can just okay.
We have to remove it.
2.5 button, please. For anchoring.
Okay, this is for holding the wire. Okay. No, but what I was thinking, they're going to exchange. What he's basically doing is keep it in the guiding catheter by its side. Wait.
Can I see the guiding, please? Guiding. Okay.
Yep.
Okay, 14. 14. 14.
10, 12, 14.
Okay.
Yeah. So it runs. Yeah. So basically, there's a balloon inside the.
Yes, the balloon is in
no,
the
no,
guiding
no,
and
no,
you
no,
are
no.
trapping and
Yes,
take it
yes,
out.
yes.
That's
Okay,
good.
1.25 button, please, for the CTU.
Shall we remove this balloon?
No.
Not now.
Please keep.
Zuna.
This is 1.25 thousand from Thermo. So
Of which balloon, which size of the balloon you are using?
this is just a 1.25.
1.25 Tazuna from
Okay.
No. From Termo. And this is-
Okay, down please. Okay, so we can
Get
dilate.
that indiflator, please.
Okay, 15. Please.
How much you have gone, the pressure?
15.
Okay.
Down.
You are not able to see it because it's not
15.
fully up. Now it will come.
Down. 15. Down. One more.
2000 heparin.
Okay, 15. Okay, down. Okay, now we move to the 2.5 button.
Can we have an angiogram?
Oh, okay.
Yeah. Okay. Okay.
しよしどうしようか
అంటే ఇప్పుడు చూపించదు డోంట్ షో ఇట్ నౌ ఐ విల్ టెల్ యూ ఓకే కెన్ యూ no not remove थोड़ा सा कम करो
Anyway, we can recognize, but we can see the
नहीं, वो
very
ठीक है,
diffuse region.
मुझे सुनना चाहिए
So
from
it's a long
inside.
segment, starting from the ostia.
But usually
And to
the distal side of the CTO is especially is shrinking. So after recolonization, the CTO, distal side will be bigger and bigger.
Because the underfilling is
Anyway, we can dilate it 2.5 inside the distance.
Yes, you can use a bigger size balloon.
But I don't want to make it the dissection, especially the distal two lumen. So inside the stent is the bigger balloon is fine, I think. But anyway, I have the 2.5, so I want to dilate it the 2.5 balloon.
Can you do a iliocranial view to see the left main? as well?
Yes, left main, actually the left main is very short. So I think we see the already just stenosis. But after ballooning, I want to check the IBUS, of course. I'll go up, 10,
okay, going 10, 9, 10,
12, 14,
Yes.
12, 14,
down,
Okay.
10, 12,
10,
12, 13,
Okay, fine.
14.
down. Okay, 10.
Okay. Dr. Sharad,
12, 14.
you continue to work. We are now moving to the hospital in Ahmedabad,
okay
and then we'll come back to you.
yeah you can just give us 5 minutes at the end of it okay
Yes.
okay right
Yes.
thank you
And
So, and can I see the wire chip? Wire chip?
so,
Okay.
good morning, Dr. Tejas
Okay.
Patel. Yes, Sharad, we have back to
Thank you. Thank you. Bye.
Can you show us what you have done?
Thank you.
you're able to hear us okay Dr. Tiwari you are able to hear me Vasu ask them to connect us we will leave it at this, yeah.
So,
Dr. Tiwari?
yes,
Yeah,
yes, yes.
You're able to hear.
We are
Okay.
hearing you. Just
Okay.
show us.
Yeah, we just give 1 second, 1 second. We're in the middle of an IVUS. We are done with this case.
Okay.
Yeah, okay, go to scene minus. We will show you from where we left.
Can you show us the final result?
No, we are just showing you. 1 second. Go back. Go back. Go back. Okay, go back once. Quick. Okay, this is where we left. You know, it has been crossed by XTR, and later when it didn't work, he used Cyan, no. Huh? No.
Sayon.
Gaia 1 and then Gaia 2. And then finally it crossed very well, and then exchanged it, dilated initially with a 1.2 Tajuna balloon, and this is what the result is, post-dilatation. Okay, next one. Yeah, we dilated it later with a 2.5 millimeter balloon. Next. Yeah. We used two stents. The distal one is a 2.5 into 26 millimeter, and after the proximal stent is R0, both are R0 stents, which is a 3.0 into 30 millimeters.
Okay.
Yes. Yeah, next one. Yeah. Next. Yeah. Now you can see the IVUS pictures. Can you show the IVUS?
Last one.
The final IVUS.
Yes.
We dilated that stented area with a 3 mm balloon throughout up to 20 atmospheres. Are you able to see the IVUS? Yep. Okay. It shows both the stents are well expanded, and the distal stent we achieved a diameter of
proximal
about
LED and
2.6, and the proximal stent up to 3 mm. This is the first one. Would you like to show one final angiography?
Yes, of course. Anyway, the stent expansion is acceptable.
Yeah. What is
And
the
this-
diameter? Yeah. The proximal stent achieved
and the-
2.9
And
mm.
please run. And the proximal stent edge position is just
Yeah.
protruding
Sure,
left
sure,
main.
there, freeze.
But this case is left main is very short, so this result is acceptable, I guess.
Yeah,
So
okay.
that we can move to the spinal energy shot. Okay.
Yeah.
distal. Okay, あれをこうだ。No, あれこうだ。
Epicardial.
Okay.
Okay, it's pretty good.
So the
Little arevo.
Little arevo.
Little arevo.
Okay.
Yeah.
Can you show us iliocranial?
No, it doesn't work.
Robert, 1 second. We will show you the final cine shot.
So it's pretty good result as expected as a complex lesion. So
Okay.
as the time is, so can you show us the final picture, and we are through to this session?
Yeah, it's on. Yeah, we can do a cine.
Distal.
Yes.
Yeah.
Okay. That today we can finish this procedure.
Okay. So, Tiwari,
So
Dr. Tiwari.
maybe the rest of the procedure you can complete and show us the result later on. So thank you, Dr. Sharat Chandra, for showing us this complex lesion and
Is
how to
offline?
do it,
Online?
the negotiating the wires,
Okay, I think
the
we are-
rest of the
we are
procedures.
not live now anymore.
And,
Anyway, thank you very much.
Thank you very much.
for
Thank you very
my
much.
case.
Thank you.
Yeah.
Dr.
Thank you.
Panja, Dr. Deepak.
Yes, sir.
वो बिना बताए